Good evening, doctors. Welcome again. Today we are going to discuss about ophthalmology, MRCP, MCQs. This is part 1A section we discussed. This is B section. A proliferative diabetic retinopathy is best treated by mainly treated by pan-retinal photocoagulation laser. Okay. A 32-year-old woman has multiple cotton wool spots noticed on the routine fundoscopy. Which of the following blood test is least helpful in determining the likely cause? So the least helpful is lipid profile. Let's discuss both answers here. Okay, firstly we discuss lipid profile. Okay, pan-retinal photocoagulation laser. Patient with proliferative diabetic retinopathy require urgent pan-retinal photocoagulation laser within 2 weeks. Tightening blood sugar control and blood pressure control is a short term can actually make the retinopathy worse, although there is long-term benefit. Macular grid laser is only appropriate for diabetic macular edema, maculopathy, not for proliferative disease. Lucentis is used for age-related macular edema, and recent trials show it is also effective for diabetic maculopathy. But it has not yet been shown to be effective for proliferative disease. Okay, now lipid profile. Abnormal lipids are unlikely to cause cotton wool spots. The fundal appearance is typically normal with hyperlipidemia. Cotton wool spots occur with HIV, retinopathy, severe anemia, systemic lupus erythematosus, signifying a flare-up of the condition, and diabetes. Okay, let's discuss which of these best describe the functions of the rods in the eye. The function of rods is vision in a dim light. Function of rod is vision in a dim light. Okay, now a 67-year-old woman who has type 2 diabetes mellitus and a previous anterior MI to the A and E with sudden painless central vision loss affecting her right eye. On examination, her blood pressure is 185/105, pulse 80, atrial fibrillation. Vision on the left is 6/18, reduced to count fingers only, and right hand side. Examination of retina on the right reveals a pale retina with a cherry red spot in the area of macula. Which of the following is the most likely diagnosis? So the diagnosis here is central retinal artery occlusion. Let's discuss both of them answers later. Let's discuss now. Rods is a vision in a dim light, cones in a colored vision, and depth perception. Rods are involved in perception of objects in dim light. CRA occlusion is associated with a pale retina apart from a cherry red spots in area of macula. Cherry red because the preserved blood supply and intact choroid vessels. Immediate referral is recommended as some blood flow and hence vision may be restored. Treatment include ocular massage, acetazolamide, and locally delivered TPA have been attempted with variable success. Okay, now discuss another MCQ. 51-year-old woman with 40-year history of type 1 diabetes comes to the emergency department complaining of sudden painless loss of vision in left eye. She has history of proliferative retinopathy which have required bilateral laser therapy in the last 2 years. You cannot clearly see the retina. She has lost the red reflex. Which of the following is most likely diagnosis? So this is a case of vitreous hemorrhage. Okay, 34-year-old woman present to the emergency department with progressive loss of vision in her left eye. She says over the past 36 hours her color vision was deteriorated and now she can only see blurred objects out of that eye. There is an afferent pupillary defect on the left, although the disc itself looks normal. Blood pressure 122/72, pulse 74. Her straight, regular. There are no other abnormal features. Which of the following is the most appropriate intervention? In this condition, we need to give her IV methylprednisolone. Let's discuss both answers. Okay. A sudden painless loss of vision coupled with a loss of red reflex and obscured retina fits best with vitreous hemorrhage. It is quite possible this has occurred as a result of neovascularization leading to formation of fragile vessels, which have a great propensity to bleed where a large hemorrhage has occurred. B-scan ultrasound is employed to determine the site of bleed. Hemorrhage may take up to 3 months to resolve. Okay, now IV methylprednisolone. The clinical picture finding on eye examination are consistent with optic neuritis. Initial therapy choices optic neuritis is IV methylprednisolone for 72 hours or oral prednisolone to complete a 2-week course corticosteroid treatment. Recovery is usually over 2 to 6 weeks, although 40 to 80% individuals develop multiple sclerosis in subsequent years. Appearance of retina does not support an infective cause such as cytomegalovirus, rhinitis, underlying visual loss here. Okay, let's discuss another MCQ. 29-year-old man with a history of ankylosing spondylitis present with bilateral eye pain, blurred vision, photophobia. On examination, there is a bilateral pupil constriction and circumcorneal redness. Slit lamp examination reveals cells in anterior chamber. Which of the following is a treatment of choice here? We are going to give prednisolone and cyclophenolate eye drops in this condition. Okay. Last but not least, 18th question for ophthalmology. A 54-year-old woman who has a history of type 2 diabetes and hypertension present to the emergency department with visual loss affecting her right eye. She says that the loss has been painless and she went from acceptable vision to count fingers. Only over a period of around 12 hours, ophthalmoscopy reveals dilated tortuous retinal vessels, cottonwool spots and retinal hemorrhages in all 4 quadrants. Which of the following complications give most cause for concern around 3 months after this event? It is due to neovascular glaucoma. Okay, let's discuss both. The diagnosis: prednisolone cyclophenolate eye drops in anterior uveitis. More frequently, patients who have seronegative arthritis or inflammatory bowel disease. It thought to be related HLA-B27 positivity. The aim of therapy are to prevent damage from prolonged inflammation, because this causes disruption to the flow of aqueous inside the eye, with glaucoma occurring adhesion between iris and lens. Drug therapies include steroids, 0.5 to 1% prednisolone drops every 2 hours to reduce inflammation, hence pain, redness, and exudate, and to prevent adhesions between lens and iris syncytia. The pupil is kept dilated with cyclophenolate, 0.5%, 1-2 drops every 8 hours. Okay. Now, neovascular glaucoma diagnosis here is central retinal vein occlusion, the long-term outcome of which variable possible improvement for 6 months to 1 year. The main problem are macular edema and neovascular glaucoma. Secondary to iris neovascularization in ischemic central retinal vein occlusion, 60% develop neovascular glaucoma called 100 days glaucoma. As it develops with this time after the occlusion, there is no validated treatment for post-occlusion macular edema. Neovascular glaucoma requires aggressive pan-retinal laser photocoagulation. Vitreous hemorrhage is not a major concern after a central retinal vein occlusion. So guys, I hope you understand till here. If you have any queries, any question, you can ask me, and if you're new on my channel, please subscribe it, and if you like this video, put like on it. Thank you, good day, goodbye. That's all for today.